in the shoulder pathology. Now, frozen shoulder. Codman first defined frozen shoulder in 1940s, and following that Nevesia, he described adhesive capsulitis as if it was a fibrosis, inflammation, and capsular contracture. As Codman rightly said, it is very difficult to define a frozen shoulder. It is difficult also to treat a frozen shoulder, and also it's very difficult to explain to the patient what exactly is wrong with them. Most of them will ask me what exactly is wrong with your shoulder. We'll have to tell them the bones and joints are normal. They're not convinced. And they'll ask me, why did it happen to me? We'll have to say, I don't know. And they're still not convinced. So it's very difficult to explain to the patient as well. And that's when they start losing confidence on the doctors. This doctor can't explain my disease to me. So it's a difficult problem really in our practice. Now, prevalence, 2 to 3% of the population, majority females, 40 to 60-year-old, non-dominant hand, they say. Etiology, unknown, but there are a few who are more prone to develop frozen shoulder. So it can be primary, which is idiopathic, or it can be secondary to a known cause. Yu et al. Has suggested that 62% of adhesive capsulitis have got a partial thickness tear if you do an MRI scan in over 50s, and this is a middle-aged population anyway. Now, if you look at the staging, this is 4, but classically 3 stages are described. They combine first 2 stages as a freezing stage, then number 3 is a frozen stage, and number 4 is the thawing phase. Now, stage 1, there is pain, and majority of the patients don't come to us at this stage. They only have pain, and they come to us only after the range of movement is actually restricted. It's hard to catch anybody at this stage. Most of them actually wait for the pain to go away, or they try painkillers and then they come to us. Stage 2 is when, along with pain, they continue to have a decreased range of movement. Now, the range of movement is not really abduction, forward elevation is not what we are looking at. It is mainly external rotation and internal rotation. Yes, abduction can be restricted in any of the pathology, but it's mainly in this plane what we are looking for. External rotation, internal rotation, along with abduction. So in stage 2, it's a Christmas tree appearance if you actually put an arthroscope. Stage 3, from there it goes on to a frozen stage where the pain slightly comes down, but the range of movement continues to be even more restricted. And from then again it goes to a thawing phase. Everybody knows about this. This is a very, I would say, misleading statement where he says 94% of idiopathic frozen shoulders recover to a normal level if you don't do anything about it. And this is at 2-year stage. And in this age group, and in this time, if you tell the patients, it will take you 2 to 3 years, but you'll be normal, I don't think they're accepting it. So we'll have to do something about breaking the cycle of these 2 to 3 years, breaking the cycle of either the pain or to increase the range of movements. So what are the available modalities presently? So we're treating the patient according to the clinical stage at presentation, and also to if there is any underlying pathology along with the frozen shoulder. It's not just a frozen shoulder. So presently NSAIDs, it's normally the first modality of treatment by a primary care physician, but there are still no level 1 or 2 study to prove its effectiveness. It can reduce the pain to a certain extent, but the range of movement, once it is restricted, it may not improve just with NSAIDs. Oral steroids, again, it provides relief of pain, but it does not improve the range of movements on its own, and they both have got systemic effects. So NSAIDs or oral steroids in the present treatment is not the only mode of treatment. Intra-articular steroid injections has shown results mainly in terms of pain relief. For example, the article in the Physicians Medical Rehabilitation has shown that 3 weeks of pain relief and then annuals in rheumatology has shown at least of 4 weeks pain relief. Along with this, if you have to add another modality to increase the range of movement, it's not only pain relief. And there's another interesting study of 109 patients comparing steroid with physical therapy. It shows at 1 year follow-up 77% success in the injection group compared to only physical therapy. This is injection with physiotherapy versus only physiotherapy. So the intraarticular steroid injections, stage 1 generally they recover within 6 weeks, stage 2 recover in 7 months. Now physical therapy is most useful when the range of movements becomes really restricted in the later phase. A Cochrane database has also shown that there is very little evidence to prove its efficacy on its own. So physical therapy on its own really is not that efficient. And also physical therapy versus home exercises. There's another study which shows that home exercises on its own is as effective as aggressive physiotherapy. Now we're looking at what surgical interventions are available. Suprascapular nerve block, the therapeutic mechanism is still not clear. A few centers are trying to provide good pain relief, but again it has to be supplemented with physiotherapy. There is insufficient data to provide its efficacy. I don't think many centers are trying it. Hydrodilatation is picking up rapidly. The concept is basically in hydrodilatation you inject a little bit of steroid, and at the same time we know it provides pain relief, we know it provides anti-inflammatory effect, and at the same time we are going to distend the whole joint, relax the capsule, and the normal saline also uses its therapeutic effect to dissolve the adhesions. So what do we do in hydrodilatation? Approximately 50, they say 52 ml is what we need to inject. It depends on the capacity of the glenohumeral joint. A few shoulders are really stiff after you inject 40 ml. It doesn't take more than that. But you should try and aim to attain at least 50 ml. You inject about 40 milligrams of depomedrol mixed with 0.5% sensorcaine, and that is the first injection. The second 2 injections is normal saline, mainly to dilate the whole glenohumeral joint. So it's done under fluoroscopy guidance. Basically we mark a point which is the superior aspect of the glenoid to enter into the glenohumeral joint. Under fluoroscopy guidance we go into the glenohumeral joint, and as a series we inject 3 injections. First is a steroid with local anesthetic, second is going to be 2 normal salines. There's an article in 2007 by Qureshi which clearly shows that he has compared with manipulation purely because manipulation and anesthesia was the gold standard before as a surgical procedure. But compared to manipulation, hydrodilatation proved much better, both VAS and constant scores at 6 months. So the manipulation and anesthesia versus home exercise, slightly better mobility at 3 months, but if you look at 6 months or 12 months, MUA and home exercises were almost the same. Arthroscopic release always is the last stage if none of these have worked. What do we do in arthroscopic release? We release the rotator interval. The coracohumeral ligament, which actually becomes thickened, we release all of that. We release the superior glenohumeral ligament. We release the middle glenohumeral ligament. Posterior capsule release, a few people do, a few don't, and Show et al. Has showed that there is no actual benefit of releasing the posterior capsule. I don't do it in my practice, but you must release the inferior glenohumeral joint, either with multiple perforations plus manipulation or with a direct cut method. But you must be really aware of the axillary nerve. So that's what we do. We just release the rotator interval to create the gap. And in my practice, really, once I see a patient with frozen shoulder, majority of them have restricted range of movements, all of them. If they don't have restricted range of movements, that's fine. I give them a try of physiotherapy and hopefully they'll improve with NSIDs, but majority have them. So all of them I give a hydrodilatation procedure, along with that physiotherapy. And majority of the patients at 2-month stage are about 80% improved, and I advise them to carry on with home exercises after that. And what home exercises is the Jenkins exercise protocol. If at 3 to 6 months they do not improve, then that's when I consider a arthroscopic release. When I do an arthroscopic release, I put an intra-articular catheter for 2 days and then start away physiotherapy straight away when they're in the hospital. That is the exercise protocol what I give them when they go home. Thank you. Any questions?
Thank you, Nitin.
Just one question. Has this hydrodilation technique been studied prospectively and has it proved that it can cut short disability from 6 months? That is first. And second, could you go into a shoulder within 6 months? You said 3 to 6 months. I mean, it's still in the freezing phase. Would you still go? You did a hydrodilation and you wait another couple of months and probably you say, okay, at 3 months not improving. Would you enter to do a capsule
exactly.
At 3 months, 4 months?
Answer to the first question. The study by Qureshi in JBJS in 2007, that has compared clearly with manipulation under anesthesia, and it shows that at 6 months, almost more than 90% of the patients are completely pain.
No, my question was on hydrodilation, not on manipulation.
He's compared hydrodilatation with manipulation. So he said, compared to manipulation under anesthesia, hydrodilatation has fared much better at 6 months. So more than 90%. His results are on hydrodilatation. So the 2007 article in Qureshi, JBJS, that shows clearly hydrodilatation improved in his practice. And there was 109 patients in that study group. Firstly. Secondly, would I enter at 5 to 6 months stage? I would say yes, because if they are continuing to be in pain, what are the options left? I've tried conservative treatment, I've tried hydrodilatation, it has not worked. What are my options left?
If you can study comparing hydrodilation with 2 shots of steroid.
See, steroid injection has given good pain relief, but it is not improving the range of motion. Hydrodilatation is not a procedure as such. It is almost like an injection, but you are injecting normal saline along with it. That's not another procedure. It's just an injection. You are distending the joint. That's all. So I don't see any real side effects or major complications of hydrodilatation. Okay, if it has not worked, what are the other options left? Because this is it now. It is an evolving phase. Hydrodilatation. I'm not saying it is the gold standard. It is an evolving stage. What are the options left? You tell me. At 6 months stage, you see a patient. You've tried steroid. You've tried hydrodilatation. It has not improved. It is still stiff.
If the pain has gone down a bit and it's the stiffness which is a major concern, I'll go in and out of the patient anyway, or arthroscopic capsular release.
Okay.
And after I have detailed the natural history of the disease to the patient.
That is exactly what we are saying. So arthroscopic capsular release again at 5 to 6 months stage. So that answers
6 months is something like, because from 3 months to 9 months, if you say a free will continue, so you take an average of 6 months. Most of the literature supports 6 months as a cutoff period when you can start operating the patient.
Because we know the results of arthroscopic release are good.
We know, because if somebody can go in early and because I'm just afraid that the inflammation process has not died down completely. It is not a silent shoulder now. It is still inflamed shoulder, and surgical insert may not come back with a vengeance if the patient fails the rehab program. That's the only concern. Of course, I would be interested to do it early if you need the patient's side.
Yeah.
Putting a scope in an adhesive capsular release might be difficult. So you have any tricks for that?
It's only in the final stage, the thawing phase, where the capsule is extremely tightened. Then putting a scope might be really difficult.
So
sometimes people have suggested anteriorly injecting saline about 30 ml and then posteriorly putting the scope.
there any study correlating radiculopathy with periarthritis?
There is, see, not correlating, but there are multiple studies showing that it can be secondary frozen shoulder, secondary to an injury or a surgery or a radiculopathy can cause frozen shoulders. Yes.
Thank you. Just coming back to the hydrodilation, it used to be very common and it went out of vogue, but increasingly a lot of surgeons now are getting back to it. And I think very soon we will be seeing a lot of publications, you know, after they've revisited hydrodilation. So,
It was out of vogue when I was training.
yeah.
I want to do research on that. I don't know what you're doing.
Now, presently, I think the confusion is between hydrodilation versus manipulation of an under anesthesia, because arthroscopy comes as a later stage
Yeah,
only.
much later stage, yeah.
So between the two, hydrodilation is really a very simple injection. 10 minutes, it's done, and they go home. Compared to manipulation, it can be really a lot of force sometimes on the syringe.
It's not easy at all, yeah.
Yeah.
Yeah. So the thing is, the discomfort which the patient feels while doing the procedure sometimes is down
put you
here
off.
actually.
It can put you off, yes.
So, but you know, in my experience, 8 to 9 out of 10 patients you see with a frozen shoulder actually settle on their own in due course of time. The physiotherapy given to them, if it is wrong, then they actually end up with more pain than when they came to you. So it is proper physio, and there's this theory by Dirk, who it's called supervised neglect. You know, you're actually following them up every 3 months, make them actually do the right exercises. If they don't do much, they stiffen up. If they do too much, it hurts. So you need to put them through a proper protocol, and you know, you'll find that, you know, suddenly they wake up and say, hey, it's all getting better. So that's what it is.
No, before hydrodilation, I always tell my patients, this is not going to, it's not a 100% guarantee. It's close to 70 to 80% that you can get better, and it can take up to 3 to 6 months. And in the last 50 patients which I've done a VAS score, a little study which I didn't put it up over here. But out of 50 patients, 41 patients improved at 6 months.
Oh, that is
so that's close to 80%, which is better than what 70 to 80% I'm telling. And they are better, and they're continuing with their physiotherapy. So it looks promising. I think another 1 or 2 years proper studies will come up. It looks promising.
If there is a partial supraspinal tear, would you inject a corticosteroid in that patient?
Good question. Now, if it is secondary frozen shoulder, secondary to a rotator cuff tears or any injury or anything, the question is, do you go ahead, do an arthroscopic release of whole thing and then repair the pathology, or do you just do this?
Because steroid might lead to a complete rupture.
It can. That's the complication. So secondary frozen shoulders, I would be very, very cautious. I would not distend the whole thing. So MRI showing any rotator cuff tears, I will not put any steroids.
But in your presentation, it showed, one of the studies showed
67%.
67%.
67%,
That is
yes.
significant, isn't it?
That is
so
significant.
that is something where you shouldn't be doing a manipulation also, because
Yeah.
the risk of tearing it completely is
And steroid
significant.
also. Injecting steroid also might lead to a complete.
Correct.
But can I say something? I mean, the frozen shoulder group is around 35 to 55, 65, approximately.
Mm.
age.
So, yeah, slightly
And
older.
You do it normal. The criteria for diagnosing frozen shoulder would be a true AP and diagnosis.
Mm.
It should not be disease. So if I'm looking at an AP, I don't find the radiological sign. So I don't believe the MRI reports of the radiologists. They always will write past.
Yes, they'll always write the partial thickness.
So I
That's
don't-
true.
I don't order an MRI in a frozen shoulder. And pasta cannot be diagnosed on a X-ray.
Sir, you approach the anterior or posterior, sir, the injection?
Anterior.
Into the joint.
Anteriorly, yeah.
Is there a difference between the two approaches?
What, for the hydrodilation?
Yes.
It's much easier to go anteriorly. There's a lot of space, because if you're looking under fluoroscopy, you're going right just above the glenoid into that little triangle. It's much easier anteriorly and much safer. Sorry?
Of 50 ml followed by 2 of 40 ml each. What is the time duration between the
At the same time.
two? Same thing.
Same sitting, the first injection is going to be a 40 milligrams of triamcinolone with 10 ml of sensorcaine. That's going to give you a little bit of local anesthesia. At the same time, after 2 minutes, we distend the joint, Through the same injection, we're not even taking out the injection. Through the same needle, you inject consecutively 40 ml.
Thank you, Nitin.
Thank you.
Very interesting. So we now go on to another talk which is very, very similar to, I mean, confusing between frozen shoulder and impingement. Very important to differentiate both of them. Can I ask Dr. Nilesh Kamath from Pune to talk to us on current concepts in treating impingement?
Good afternoon, everybody. A brief note of thanks to Honorable Chairman and the organizing team. Well, I was asked to talk about impingement syndrome, and what is most important is, let us try to answer the most fundamental question. It's not unusual that a patient comes in, a middle-aged lady or a gentleman with a painful shoulder, inability to abduct comfortably. Do you label that as impingement straight away? Because trust me, more than 50% of your MRIs is going to show changes either of tendinosis, whether of an interstitial tear, or then do you actually wait for it to progress to a partial tear or a full thickness tear? To answer this question, it's worthwhile to actually go back into history and try to understand that how did a painful shoulder evaluation actually start off. It was in 1860 that first time a painful shoulder secondary to subacromial bursitis was described. But it was the father of shoulder surgery, that's Codman, who described about a supraspinal rupture without history of trauma. Nevazier in 1950s probably described that it can happen both with trauma and without trauma. But it was Charles Neal who opened the actual door to management of impingement in 1970s. So what was it that Charles Neal did so differently that we give so much of weightage to what he did? If you understand the standard of care in 1960s, it was a lateral acromionectomy for nearly more or less all painful shoulders. That means you are resecting the entire lateral aspect of the acromion. What are you doing here is that you're detaching the deltoid. So you are causing real problems for the patient in the form of poor outcomes, weakness, infections and sinuses. And that is where Charles Neal thought that it's worthwhile to think about or to examine the undersurface of this acromion. So in this landmark paper that he published in 1972, what he did was single-handedly, mind you, single-handedly, he dissected 100 scapulae and tried to understand the morphology of the acromion. There were two things that he figured out. Number one is that abduction does not take place in the lateral plane and it takes place in the plane of scapula. So the first area which comes in contact with the undersurface of the scapula is undersurface of the acromion is only the anterior-inferior portion and not the entire lateral portion. That's how he concluded that it's the anterior-inferior portion of the acromion with the associated excrescences that needs to be excised. This was back in 1970s. Medicine has always evolved and so has the management of impingement. So what is the present trend in understanding impingement? No more impingement is spoken about as one particular entity, but it's classified or spoken about under 4 different headings. It could either be a primary impingement, or it could be a secondary impingement, or a subcoracoid or internal impingement. Let's take a brief on each one of this. What is primary impingement? This is more or less similar to what Charles Neal had described, where the rotator cuff is impinging against the undersurface of the acromion, resulting in loss of motion with associated weakness. He had described that it goes through various stages, mainly edema followed by fibrosis and then proceeding on to a complete tear. So effectively, it's a continuum. It's not one single entity. Clinically, the patients come with a painful restricted motion. Your Hawkins might be positive. Likewise, your impingement sign may be positive and your impingement test may be positive. Now, just going back to the previous talk, when I have to inject the shoulder in the subacromial space, I go posteriorly. As opposed to that, when I have to go intra-articular, I go anteriorly. Because I feel as a shoulder arthroscopy surgeon, I'm much more comfortable going into subacromial space from the posterior aspect, gives me adequate space in the posterior region to inject my bupivacaine with triamcinolone. Continuing with the talk, if you think about primary impingement, what causes it? It could either be an extrinsic or intrinsic. Extrinsic simply means that there is a problem with volume. Intrinsic means that the structures out there, that means the cuff and the bursa, are at problem. And extrinsic, as I told you, volume loss is there. So either there is a spur, or there is a morphology change, or there is an osteophyte which is up there. There was a lot of discussion on what x-rays to advise. It's worthwhile to get this view in the management of any shoulder problem. For me, any patient who walks in my clinic with a painful shoulder, irrespective of the history, I always get 3 x-rays, a true AP, an axillary lateral, and a scapular wide view. Why is the scapular wide view so important? It's because first we need to understand how to assess this radiograph. It's equivalent to Y. The anterior portion is where you look for the coracoid. The posterior is the spine. So track back the spine, and this is the acromion. So what are you supposed to look for is along the anterior aspect of the acromion, you're trying to look for a spur or an altered morphology. You can go ahead and order an MRI. On MRI, again, you would see the same thing on a sagittal picture. But if you go in for an arthroscopy, this is what you would see. You can see a partial surface bursal site there on the rotator cuff and a corresponding acromial spur out there, which is causing the impingement whenever you're doing an overhead abduction. The morphology was actually described by Bigliani, and so much of importance was given at that point because in the cadaver study of 140 shoulder, there were high association of a rotator cuff tear with a hooked acromion. But that thought process is changing. It's not necessary that every hooked acromion will have a rotator cuff tear. Further, lots of parameters were described, namely the slope, the tilt, the lateral acromion angle. But trust me, these are more so from theoretical perspective. You wouldn't do them daily in your outpatient clinic. Other conditions which would mimic an impingement, which should cause the impingement, would be AC joint arthrosis with an inferior osteophyte, or an os acromial. Now this is a relatively rare condition, but you can still get it. That means an unfused acromion, especially the meso part of it, this comes into picture, so this is effectively mobile. So when you're doing an overhead abduction, the deltoid is pulling this mesoacromion because of its attachment here, and that causes an impingement. How do you treat this? Well, it's a very standard protocol that we have been following for quite some time, and this is what we need to do. You start off with activity modification and non-steroidal anti-inflammatories, 1 to 2 subacromial injections. I probably space them minimum of at least 6 to 12 weeks. So I'm talking about 1.5 to 4 months. Physical therapy program mainly to stabilize the scapula because there's an altered dynamics of the scapula out here. If there is no response, then you consider operative intervention only if you have found that it's a primary pathology. If it's not a primary pathology, we'll discuss about that eventually, what needs to be done. If you're going in for an operative intervention, what do? There are certain principles here, and these principles are prudent. Let's go through this video and understand what are the principles. I'm looking at this right shoulder from behind, posterior viewing portal, medial on the left side, lateral on the right side. So you can see that there is an acromial spur. First thing is start releasing the entire soft tissue. After identifying the spur, then you don't cut the coracoacromial ligament. You try to peel it off. There is adequate importance of the coracoacromial ligament, so you're not supposed to cut it. So you can very well see that there is a plane of cleavage out here, and the coracoacromial ligament is being released off the surface of the acromion. Only once you do this, again put in your shaver and try to clear off the remaining debris. Once you start seeing this kind of picture, this is the right time to use your burr to start doing an acromioplasty. How to go about an acromioplasty? There are 2 ways to do this. Either you can view from behind with your acromionizer on the lateral portal and try to make it coplanar in such a manner that there is adequate space, or you go ahead with a cutting block technique. Now what is a cutting block technique? This is where your scope comes in the lateral portal and you work from behind. So the simple principle is you are going to make it as much coplanar till you try to become parallel with the acromionizer. So you can see towards the end of this video, finally your acromionizer can actually sit in flat against the undersurface of the acromion. That tells you that it's a good endpoint, and that's good enough to prevent an acromial fracture. You can also do this arthroscopic, open way if you're not an arthroscopic surgeon. But remember, what was taught by Neer in 1970s still holds good. If you're doing it open, preservation of the deltoid origin is very important. You're doing adequate exposure of the cuff to find out an associated pathology, because if there's a cuff tear, you're going to sort it out at that sitting itself. And decompression of impingement. If you would ask me my personal take, well, I try to prefer going arthroscopic. During my residency, I have gone through the open way. I don't think that you can do that much justice as what you could do arthroscopic for these particular problems. Understanding secondary impingement is a different ball game altogether. Here there is no volume loss, but there is a dynamic imbalance. So if there is a dynamic imbalance, so effectively what happens is there is a relative narrowing of the subacromial space. That means even if there is no volume reduction, but still relative narrowing. What are the conditions which can cause this? Mainly all the conditions where the dynamics are affected, and when you're going to do an overhead abduction causing pain is how the patient would present it. So to understand the dynamics associated, if you go back to anatomy days, the deltoid tries to pull the humeral head up, whereas the rotator cuff collectively is a depressor and pushes it against the glenoid. So this balance is in equilibrium. Any condition which is going to disrupt this balance is going to cause pain. So first condition is a rotator cuff dysfunction, and by this I'm not talking about cuff tear. There are patients who don't have their rotator cuff firing up well, and if there is a loss of this equilibrium, that's going to bring on pain. Likewise, glenohumeral instability. Translation of the humeral head typically anteriorly and superiorly is again going to cause abutment against the coracoacromial arch. Scapula, I can't emphasize enough on the movement of scapula, because if the scapular mobility is not good, again patients will have problems and will come to you saying that they have something like an external impingement. Now, why is all this important? Because secondary impingement happens in young overhead athletes, and gone are the days where India doesn't have any overhead athletes. Trust me, even in my clinic, I get to see patients playing at club level, at university level, and that's why it is important that they get back to their full-blown activity. Physical examination, you're looking for associated features, so either glenohumeral instability or you're looking for scapular dyskinesia or a sick scapula. In patients with secondary impingement, the treatment of the underlying problem takes care of the impingement. So mind you, don't jump up being a surgeon and trying to go in for an arthroscopic release, because if you burn your hands here, it's going to cause more issues. Doing a subacromial decompression in a secondary impingement is going to worsen the clinical picture of the patient. Coming to subcoracoid impingement, now what was described by Job for an external impingement, by Neer for an external impingement, something similar was described by Gerber for an coracoid impingement. So the analogy here is, instead of supraspinatus, we are talking about the subscapularis. Instead of the undersurface of the acromion, we are talking about the coracoid. It's not something which is present routinely, but this is something that you need to be aware about. It's something which can be picked up on clinical. There is pain on the coracoid, but MRI would be able to pick up the diagnosis for you. Lastly, coming to internal impingement, Dr. Samantha has already spoken about this. This is an entity which is described by Gilles Walsh, seen classically in overhead athletes. The problem here is not the superior surface of the cuff, it is the undersurface of the cuff. So injury and dysfunction due to repeated contact between the undersurface of the rotator cuff tendons and the posterior superior glenoid, which happens whenever you're getting your hand into abduction and external rotation. So this is classically seen in those patients who are doing a lot of throwing activities. So cricketers do present with this, especially those who are fielding in the outfield. Early in the course, if you do put them through good rehab, then they do very well. What you're not supposed to miss is associated slaps, associated undersurface tears. If they fail conservative therapy, then you need to consider surgical treatment for them. So what do we remember from this entire discussion? Number one, whatever the type of impingement, early diagnosis is key to management. the eyes see what the mind knows. That means if you know about secondary impingement, then you are going to differentiate it from primary impingement. Supervised rehab is helpful in majority of the cases. If at all surgical intervention is required, follow Neer's principles. They still hold good true after 40 years. Thank you.
Thank you, Nilesh, for the excellent presentation. Any questions, please?
Sir,
Yeah.
if you want to say one clinical test which gives a good sensitivity and specificity for impingement.
For
what is it,
impingement,
sir?
Hawkins would be good. Hawkins would be good. But you're looking at the overall clinical spectrum. You're not looking at one particular test. Nowhere in shoulder, even let it be SLAP or labral pathologies, there's not one test to diagnose a particular condition. You're looking at the history, you're looking at the clinical findings, and then you're seeing that, okay, this test seems to be positive. For example, in SLAP, there's so much of emphasis on O'Brien's, but there's adequate evidence that single-handedly O'Brien's cannot tell you about a SLAP. So O'Brien's with Jobs has the highest specificity and sensitivity for a SLAP test.
Nilesh,
Minimum
in your,
2 tests.
In your practice,
Yes.
do you feel that just doing an arthroscopic subacromial decompression or an acromioplasty has come down of late?
Oh yes, definitely. And that's why even in my take-home points, I mentioned arthroscopy just as a surgical intervention, just as a last word. Because if you stabilize the scapula, luckily I have the services available of a good trained physiotherapist who is well versed with myofascial releases and with scapular taping. And I've seen that whenever you do a scapular taping, the dynamics of the shoulder change so much so that considerable amount of patients go down on their NSAID intake as well. So
Absolutely.
it's gone down considerably.
Okay, thank you very
Right,
much.
thank you.
I now call on Dr. Rakesh Arya from Delhi. He's going to talk to us on double row rotator cuff repair. Those of you who came in later, actually single row was already done as the first talk. So, Dr. Arya, please. Thank you.
Thank you, Mr. Chairperson, for inviting me. I'm from Delhi, and those who are not aware, and I work with Max Healthcare, and this just shows that outside is even messier than the hospital, messier than what it appears in the photograph. So now the double row or rotator cuff surgery as such is controversial. Whether you do open or arthroscopic, good quality repair is more important whether you are doing mini open or arthroscopic. Subacromial decompression alone, the role is still doubtful, and rotator cuff alone is important besides the subacromial decompression, and single row or double row, that is the controversy. Now, the goal of cuff repair is, to begin with, it started as a single row repair, then second generation it was unlinked. Unlinked means independent single row, independent medial and lateral repair, and the next generation it has come down to bridging of the medial row and lateral row, what is called the suture bridge techniques. So to understand double row, why double row is needed, we have to understand that it is not a one point where the cuff is attached. There is a footprint area of the attachment, and this just shows that there is a cuff there, but the area of footprint is much bigger than it is shown in this MRI cut. This is just a pictorial representation of what a single row and what a double row means. A double row covers the footprint area, compresses the cuff at the site of attachment. Again, a pictorial representation of single row and a double row. Now, the footprint of cuff normally has a width of about 12 to 15 mm, while a single row repair will cover only about 5 to 6 mm of contact. So, dual row restores 100% footprint, while a single row restores 47%. Why dual row repair? Because it compresses there are many studies where it has been shown that a dual row will restore the anatomy, the repair is probably stronger, so the rehab can be started earlier, and probably the results are better, especially in large tears. Advantages: the higher load to failure, the self-reinforcing character, especially in suture bridge technique, better resistance to shear and rotational forces, and probably higher clinical healing rates. And it restores the footprint, minimizes the pop motion at the repair site, minimizes synovial fluid migration into the repair site, and extended healing surface. The area of healing surface is much bigger and has a much improved biomechanical strength with multiple points of fixation. So these are the principles of having a double row repair rather than a single row repair. In the summary of the literature, it has been proven that dual row restores better footprint. Dual row has stronger ultimate tensile load and cyclic loading and less gap formation. Suture bridge technique is better than two independent rows because of the increased contact pressure and area. So even Sugaya, who has always advocated dual row, in his study 86 patient 31 months post follow-up double row, 83% cuff integrity has been reported in follow-up MRIs. Now, criticism of dual row is that potential for over tightening increases surgical time, increased technical difficulty, and of course, in our condition, you need more implant, and that is why the cost is much more, and that is why dual row. Now, the technique wise, there are two ways: either two separate rows, the medial row and the lateral row, or suture bridge technique. This just represents a suture bridge technique, and there are different ways of connecting the medial row and the lateral row. This is so to begin with, the basic principles of rotator cuff repair, the margin convergence, and followed by suture bridge technique. This just shows.
And we'll use this is my medial row, which I'll place as a mattress. You can see now the two purple limbs of the orthocord. And now we'll place these sutures using the espresso. I place all the sutures at the same time.
Can we switch off the volume? Volume नहीं चाहिए. नहीं चाहिए.
I'll place these next anchors.
कहाँ से आएगा? इसमें कहाँ? यहाँ पर बाहर नहीं है सर. बाहर नहीं है. Now this is a small clipping of a two-row technique where you pass the sutures first in the medial row and then the lateral row. And then we can connect to the two rows. And this is the final repair of the two rows. Where the contact area, the footprint is completely covered, and the repair is almost watertight in double row suture bridge technique. To conclude, single row mesolenal type is sufficient for small tears, maybe about less than 2 centimeter, and double row or suture bridge construct good for large tears. The size, if more than 2 centimeter, then the suture bridge technique gives a better results with the repair. Only thing we have to remember is that there is more strain put on the musculotendinous junction in a double row technique, and if the re-tear develops because of the very strong construct at the repair site, the re-tear occurs at the musculotendinous junction, and the repair in these cases is much more difficult than the primary repair. Thank you very much.
Thank you, Dr. Arya. Any questions for Dr. Arya? So do you decide beforehand, before you actually do the scopy, that you're going to do a single row or a double row?
No,
Or
always
you
on the table.
Fair enough, I think. Okay, thank you very much. The last topic for this session, Dr. Mishra is here. I don't think he's turned up, so that ends the shoulder symposium. Thank you all for a patient hearing. One of them missing.
Yeah. I think now the next session will start.
Yeah, next session.
All right. So the chairman for the next session, Dr. Inder Pawar and Dr. Vijay, are they here? If they are not there, it's okay. I think we'll start the session. Maybe I'll chair then. With me, anyone you can sit or anyone can come with me. Yeah.
It's very visual. It's more visual than your scopy pictures. It's very easy to understand. Sure.
So, Milind, you are ready already. That's the promptness. Very good. Hi, sir. So, Dr. Kumar is with me. Actually, there is a message that we have to finish everything, all the programs by 3 o'clock because there is a very good lecture by Shiv Khera. So, after this session, there is a PG quiz which I have to conduct. Will take an hour. So, let's see how fast we can move and we can finish the things because none of us want to miss the lecture by Mr. Shiv Khera. So I think without wasting any time, Emil, you are going to start your, and it's a lower limb lengthening, and a lot of cases, 699 degenerate. Let's see, please.
Mr. Chairman, sir, thank you very much. Limb lengthening is a very fascinating endeavor which I have been doing for the last 24 years. This is a series that I have culled since 2001, 699 regenerate lengthenings in the lower extremity, and some basic analysis. The time is too short to get into a thorough statistical analysis. Just I would like to give a brief jhalak, if I may. Very briefly, we had 491 TBA, in which we did from 12 to 20 centimeters, minimum 2 centimeters to maximum 20 centimeters at a time. In the femur, we had 208, and we did from 2.5 centimeters minimum to 17 centimeters maximum in one stage of lengthening. Now I'll just briefly give some clinical examples, how to lengthen, where it's used. So this is a young girl with growth arrest due to osteomyelitis with growth arrest of the proximal humerus. You can see this is a scanogram which shows the difference 14 centimeters, and it's for a pretty young girl. It's very important for her to have a proper appearance. So we do a LRS fixator can be applied here. I'll show a few examples of LRS, few of lengthening over nails, but most were done with Ilizarov fixator. So, just 2 or 3 pins are applied. These may be HA coated. A tiny incision is taken 5 millimeters to perform the corticotomy, and then gradual distraction is done. We carefully monitor the regenerate for its appearance and the interzone and the homogeneity of the bone formation, etc. And we can go on to get as much as 14 centimeters of length like this. As you can see, I have added some pins. There were only 2 at the beginning. I have added 1 more, and now her upper limb lengths are equal and her function is completely restored like this. Now, which hardware can we use for lengthening? We have used all. Now, this gentleman had a post-traumatic shortening of about 15 centimeters. He had a non-union in the femur over a nail and some shortening in the tibia and deformity as well. So we did both. We used LRS fixator in the femur. We did a proximal lengthening and compressed with the LRS to achieve union, as well as we lengthened about more than 8 or 9 centimeters in the tibia, 10 centimeters in the tibia to correct his deformity, as well as we did a foot deformity correction with a opening wedge osteotomy. And here he is with equal leg lengths and perfectly restored mechanical axis, and the femur is also healed up as well. So we used both the Ilizarov as well as the LRS. Now here is this young lad, 16 centimeters shortening. He is about 17 years of age. Growth is almost over. And so what can we use in his case? If you use the Ilizarov, it will take too long. So we use the lengthening over a nail technique very judiciously. These are special nails. We have designed straight nails there with holes or something. We need all diameters and all lengths. So this is a pre-op planning. This is a magnification marker. We need high quality X-rays in the AP and lateral plane. So here you can see the nail has been inserted from above because you can't insert from below. Its nail is locked distally. A polar screw is narrowing the track of the nail. Corticotomy is done at the site of the deformity. The Ilizarov is used in the tibia, which is really good to correct the length as well as the deformity, both rotational and angulatory, because he has an ankle varus and upper tibial varus. So here you can see that 7 centimeters of length is gained in the femur. The nail is slid down from the previous nail, which was very high. It has slid down, and as soon as this is achieved, we lock the nail, and we lock the nail above. We just kept the fixator on for some more time for stability, and you can see his mechanical axis is restored, length is achieved, and he has an excellent clinical result. If we don't use the LON technique, the fixator may stay on the femur for a very long time and may predispose to knee stiffness. So this is the benefit of LON. So where to lengthen? Just a few examples. This is a young child with very severe posteromedial bowing of the tibia, and you can see 45 degree, 40 degree deformity here. So it's no use trying to lengthen here or do 2 levels in this small boy of 4 years. So we did lengthening at the apex of the deformity. We have to go a little slow because there can be sclerosis. So you judiciously decide. And here we have nicely achieved, given him a little less, 3 centimeters only. This is at the end, axis is restored, length is a little bit short, and he comes back 3 years later for a second lengthening like this, in which case we perform a proximal lengthening. And here he is 4 years after the second lengthening as well, and you can see a very little bit of shortening is still persisting, but he's excellent result, and he's playing football at school. Now when we do congenital pseudoarthrosis of tibia, which is multiply operated, an unhealed bone like this, we also need to equalize. You can see the leg is very short. In this case, we perform a lengthening very high up using a jiggly saw. Very proximal lengthening needs to be done. If you go a little below, you may be, disastrous result. You may get complete absence of bone formation. And we also do other things like intramedullary nail, periosteal graft, inner table iliac crest graft, good compression, and a foot frame for stability. And the nail is helping to prevent the recurrence of the refracture and recurrence of the deformity. So here he is, 4 centimeters length is achieved, and the CPT has completely healed up. When to lengthen, this is one of the very few cases remaining. This is a small child. At 15 months of age, he came to me, congenital posteromedial bowing. Sorry about the x-rays. And I have written at appropriate age, we can do this. So his father said, why can't you do it now? Because he's going to further shorten. In boys, whatever is the shortening at the age 4 years will double at skeletal maturity. And in girls, whatever is the shortening at age 3 years will double at skeletal maturity. It's a rule of the thumb, which you can easily follow. Otherwise, there are multiplier charts. So we knew that he's 3 centimeters at this age. He would be close to 4 centimeters at the age of 4 years. Or, close to 6 centimeters. So he would be 12 centimeters short, which is a big task. So it's better to start early. So we did. And you can see the amount of regenerate lengthening in the middle. The child is happily playing about because the fixator is stable and pain-free. And he went on to get a good result like this. So I'll just quickly describe the major complications. We had neuropraxia in 5 cases, 4 lateral popliteal, 1 medial popliteal. All of them recovered. In only one case, we had to remove a wire from near the fibula. And the other cases, we slowed and stopped the lengthening and the nerve recovered. We did not have any permanent deficits. DVT and pulmonary embolism in one case we saw, and we were fortunate enough to detect it. We had to keep him in an ICU, and the patient completely recovered. This is a tibia lengthening case. We don't know why it happened. Probably the patient wasn't moving. It's a very rare case, but I'm very, very glad that we could save the patient from a really, but it's one case out of 700. There were no arterial injuries, fortunately. Target length was not achieved in 7 of the almost 700. Bone grafting was needed to rescue the regenerate was in only 8 cases. They were really bad cases with extreme soft tissue loss and very poor conditions, including smoking, etc., which is still just about 1%. Axial deviations of more than 15 degrees were seen in much more, say about 2.5% of cases, and these can sometimes be difficult to manage. Some other major complications, refracture after removal was seen only in 4 out of 700, in stark contrast to a lot of series which have reported a dramatically high rate. From the series of song from Korea, the rates can be as much as 10% or 20%. So premature consolidation goes to show that we have, the regenerate quality is very good. We got quite a large number of these, almost 4.5%. Hip dislocation, unfortunately, we saw this is many years ago when the parents insisted on excessive lengthening in congenital short femur. And knee subluxation, 2 cases were seen when we lengthened the femur, anterior subluxation, which we reduced with the help of the apparatus. And we have to keep an eye on for the joint above and joint below. That's the message. Ring sequestrum from the pins which are inserted were seen in 9 cases, and they required a small surgery to curate it out. It's not a major complication, but just to complete it. In most of the cases, we did drill hole corticotomies because since the last 14 years, we are mostly doing shank spins. So you cannot do a classical corticotomy in many. Most of these were done in little children. And a jiggly saw corticotomy was done in the post-traumatic cases in the tibia, especially for lengthening in post-traumatic cases, say bone transport, etc. We started, as I said, minimum, but actually 15 months, and the oldest patient we had was 67 in a non-union infected supracondylar non-union, in which we lengthened 5 centimeters. So then I will end with how much to lengthen. Just 2 examples now. In achondroplasia, this is commonest form of dwarfism. Like this, we can start with cross lengthening. In the femur, we have performed 10 centimeters of lengthening. In the tibia, at 2 levels, 12.5 centimeters. To give this child 9 inches or 22.5 centimeters. Then the contralateral side was operated upon, and here you can see she has excellent. Then we started with the humerus and gave her 9 centimeters to equalize the body proportions because the arms only reach the trochanter. And here she is at the end of the treatment with her father, and she has straight limbs, although she had some minor axial deviations which were corrected. And here is her excellent function. And so in achondroplasia, you need to give maximum length. A small amount doesn't help. Finally, I will absolutely finally end up with a very rare example. We do sometimes cosmetic lengthening in intelligent, motivated, and very understanding patients like this software engineer working in Canada. He desired, and he was very thorough with his rehab post-op. He was walking 6 hours a day, and studying the rest of the time, and he got a good 6 centimeters of lengthening with no axial deviations and excellent function. So I thank you very much for your attention.
Thank you, Mr. Chaudhary. Any questions?
Yes.
You showed 2 cases of congenital pseudoarthrosis separated multiple times. Do you think the union was achieved only with X0 and the lengthening, and was there any other bone grafting or anything?
Yeah, we have done. Yeah, many times we are now for the
So
last
these 2
12 years.
cases
Yeah,
was done?
we have done. We have done.
Do you think only bone grafting is alone is sufficient? Because most of the
Sorry,
times
it
operators-
is. It's very difficult to achieve union, whatever you do.
But
So
in
you
these 2
heard.
cases, what you showed
We have-
was
we have
only
done.
bone grafting or any
Yeah.
vascularized fibular graft?
No, no, no. Vascularized fibular graft we have done in only one.
Oh.
Cha. Thank you.
Yeah. Thank you very much. I call upon the second,
Dr. Rajesh Arora.
Dr. Rajesh Arora.
Just to remind all the speaker, as you have seen, the total time is 7 minutes if you don't want discussion. So it's better that if you keep this presentation for